Good morning once again, and welcome to the second session of the APLC summit this year. And the second session will be focusing on CLL, and I'm Dr. Eric Zhe from Hong Kong, China, and I'm co-chairing this session with Professor Li Jingyong from Nanjing, China. So it's our privilege to have our speaker from Germany to talk about CLL. So let me now ask Professor Li to introduce our speaker.
Okay. Good morning, everyone. It's my great honor to be invited to attend this meeting and co-chair this session with Professor Eric Zhe. Next speaker is Professor Osman Sawaf. He's the hematologist and medical oncologist at University Hospital Cologne and visiting scientist at the Francis Crick Institute, London. A key figure in the German CLL study group. He has been pivotal trials shaping venetoclax and obinutuzumab-based therapies in his research bridges clinical oncology and computational science with focus on cell evolution, metabolism, and target therapy. Through high-impact publications and international leader, Dr. L. Sawaf advanced personal care and innovation in hematologic oncology. Now, his title is Involving Concepts in CLL 2025. Professor L. Sawaf, please.
Thank you very much, Professor Li, and for this generous introduction. It's a pleasure to be here with you virtually. And I was asked to give an overview on evolving concepts in CLL in 2025. And so what I'd like to do is first summarize some of the items that we currently have in the first-line setting, in particular when it comes to managing CLL, and which ways we basically approach CLL and which factors are relevant when considering what kind of therapy to choose for patients with CLL, and what risk factors we have to take into account when trying to shape the specific treatment for our patients. And as one example, I've used the ESMO guidelines here, which are established mostly in Europe for the European healthcare setting. Naturally, though, there are a lot of differences in terms of access to different therapies and reimbursement of different therapies also within Europe. And so it will probably also be the same way in your region in Eastern Asia, where the access and approval of specific therapies might differ. But generally what you can see, first of all, is that largely targeted treatments are the main choice for all settings in CLL nowadays. And the key distinction that is being made in CLL is really based on the IGHV status and the TP53 status. These are the main stratifiers that guide us into how to approach CLL. And even though in the past decade we've seen a lot of studies trying to characterize the genomic landscape of CLL and to identify driver gene alterations that might have a functional or clinical impact, we still have only basically two factors that we know have independent prognostic value. So even though we know there are some driver gene alterations in NOTCH1 or in SF3B1 and so on that do affect a certain fraction of patients, whenever we adjust in these models for the presence of TP53 or IGHV, we see that these two variables are the only ones that are really independently associated with survival, in contrast to all other driver gene alterations, which so far have not been identified as such. And so these variables are relevant because they have different impact on progression-free survival in particular, and on the duration of the remission that the patients might experience. This is now a study pooling different data on continuous BTK inhibition with acalabrutinib, suggesting that the IGHV status is not prognostic in the context of continuous BTK inhibition. And we've seen this with all other BTK inhibitors as well. As an example here for zanubrutinib, where you can see from the Sequoia study that when patients have an unmutated IGHV status in the upper curves, that the PFS is similar whether they have an unmutated IGHV status or a mutated IGHV. And this is very different to what we know for chemo monotherapy, as you can see in the comparator arm for bendamustine rituximab in red. These are patients who have an unmutated IGHV status who have significantly earlier progressions. So in that sense, the IGHV status here is not just prognostic, but actually also predictive. With fixed duration treatments, we see some interesting patterns. First of all, of course, we see that the efficacy of venetoclax with the CD20 antibody is higher than with chemo monotherapy, especially when you have an unmutated IGHV status. But notably, you do see that those with mutated IGHV do significantly better than those with unmutated IGHV in the context of fixed duration targeted treatment. So this suggests that in contrast to continuous BTK inhibition, we do notice that the unmutated IGHV status is still prognostic. And therefore, we have a difference here to the continuous treatment strategy. But what's interesting is when we look at very long follow-up and observations for these patients, that the time to next treatment, even when we have an unmutated IGHV status, is extremely long. So this means that even when you have an unmutated IGHV status as an intermediate risk factor, so to speak, the patients will most likely not require a next line of treatment for more than 6 or 7 years, even though they have unmutated IGHV. And so this does suggest that the treatment-free survival that is generated with a fixed duration targeted treatment is really quite substantial, also when you are using a fixed duration targeted treatment. And these data were largely confirmed also in CLL13, and notably also for venetoclax and ibrutinib, which is also an established combination that shows high efficacy as a fixed duration strategy, but where we also see that unmutated IGHV is prognostic compared to continuous treatment. And so it seems that it's not so much a question of what kind of combination therapy we use, but more the fact that a fixed duration treatment seems to be more associated with shorter PFS, but very meaningful treatment-free survival. And very recently, we also got the first data from the AMPLIFY study that demonstrated that acalabrutinib and venetoclax are also an effective combination. But as you can see in the upper curve, the double therapy venetoclax and acalabrutinib, here we see a similar progression-free, we see a similar pattern with unmutated IGHV being associated with shorter PFS. Interestingly, the triple treatment where we add a CD20 antibody, in that context, the unmutated IGHV status does not seem to be particularly prognostic. The follow-up is still fairly short of this trial, but it does suggest that maybe intensive treatment can overcome this pattern, even though this comes at the cost of substantially more toxicity. So therefore, as we'll discuss later, this might probably not be a sufficient reason to choose triple treatment. So we very recently updated our Oncopedia guideline, which is basically a consensus guideline that is established in Germany, Austria, and Switzerland, so in the German-speaking parts of Europe, and we included acalabrutinib and venetoclax into this algorithm as well. And what we said is that for mutated IGHV, generally we feel, or we see from the published data from CLL13 and 14 in particular, that the combination of venetoclax and obinutuzumab seems to provide the best balance of longest efficacy with shortest treatment. And generally, fixed duration treatment should be preferred for mutated IGHV by all means. This affects approximately 40% of previously untreated CLL who have excellent outcomes with a limited duration approach. For patients with unmutated IGHV, what we do observe is that a treatment with a fixed duration approach, be it with venetoclax and a CD20 antibody or with a BTK inhibitor, are all equal options to continuous treatment strategies, because even though we know that the fixed duration treatment is associated with a shorter PFS in the context of unmutated IGHV, the treatment-free survival generated with the fixed duration approach seems to that to be more favorable overall clinically than a continuous treatment strategy. The other clinically relevant variable is TP53, and this is a universal risk factor in all malignant diseases, and we know that even with continuous BTK inhibition, the TP53 status is associated with a shorter PFS. This has been again uniformly seen for acalabrutinib, for zanubrutinib, and eventually also for ibrutinib in these long follow-up data. And therefore, it means that this is not a predictive factor in that sense, but a prognostic factor. And naturally, we see the same also with fixed duration treatment, even though the data are more sparse when it comes to randomized data sets and TP53. But what we have here is that the patients who had TP53 alterations and received fixed duration venetoclax or obinutuzumab, the median PFS was 52 months. So we do gain a certain degree of disease control for a couple of years, but this is naturally worse than what we have with in patients who do not have TP53 alterations. On that note, these 25 patients that we are looking here in CLL 14 are so far the only randomized patients who received the fixed duration targeted treatment in a randomized clinical trial. And therefore, we really have a huge data gap still for this subgroup of patients. Venetoclax ibrutinib does not have, for venetoclax ibrutinib, we do not have any randomized evidence on TP53. We do have non-randomized phase 2 data from the Captivate trial that does suggest that also with a fixed duration treatment with venetoclax ibrutinib, TP53 alterations are associated with a significantly shorter PFS. In fact, it's around 49 months median PFS for this group of patients. So fairly similar to what we see also for venetoclax and obinutuzumab. Because we see these adverse outcomes both with continuous and with fixed duration double therapy, there have been some attempts to study a triple treatment for patients with TP53 altered disease. Again, it's not randomized data, but what you can see on the left are data from our study group showing venetoclax, ibrutinib, and obinutuzumab exclusively in patients with TP53 alterations. And you can see that the 3-year PFS is around about 70%, 75%. So therefore suggesting that there is efficacy, but again, it's not as good as you would see in patients without TP53 alterations. And on the right, you can see interesting data from the US, from the AVO trial, that does have patients with and without TP53 alterations receiving this triple treatment of acala, venetoclax, and obinutuzumab. And you can see the very clear adverse prognostic impact that TP53 alterations have. And therefore, it's at this stage, in my view, not clearly evident what the benefit of the triple treatment is also for TP53 altered disease. And therefore, to understand who and whether there is benefit of intensified treatment, there is one ongoing CLL trial, the CLL 16 trial running in Europe, in which patients are randomized to receive a double therapy of venetoclax or obinutuzumab or a triple treatment of acalabrutinib, venetoclax, and obinutuzumab. One further risk factor that is not as established in international guidelines so much, but more so in the German guidelines, is complex karyotype. This is an interesting variable because it's eventually a surrogate for genomic instability that is always biologically a contributor to clonal diversity and resistance, eventual resistance in malignancies. And in CLL, we basically distinguish between a complex karyotype defined by 3 or more alterations, or a highly complex karyotype defined by 5 or more chromosomal alterations. And this can affect up to 15% of patients with previously untreated CLL. So it's not a particularly uncommon risk factor. And it's relevant because we know that with with most targeted therapies, we see a sustained adverse impact of particularly highly complex karyotypes. So we do notice that also with 3 chromosomal alterations, be it with venetoclax obinutuzumab or be it with venetoclax and ibrutinib, here indicated in the purple curve, we do see an adverse prognostic impact of having 3 or more chromosomal alterations. When it comes to venetoclax and obinutuzumab, especially highly complex karyotype, as seen here from the CLL13 trial, is associated with a shorter PFS. And the randomized data for continuous BTK inhibition are a little bit more limited here, but this is from a large pooled analysis from the US, where you can again see that the more chromosomal alterations you have, the shorter the PFS is. So this is indicated here with these blue curves, where you can see that when you have extremely complex karyotypes, the progression-free survival is eventually shorter. So we don't have a very good feeling for whether continuous treatment really has a different impact on complex karyotype than a fixed duration treatment. What we do assume, though, in our treatment guideline is that the more aggressive the disease is, the more conservative we would be in saying that patients who do have more aggressive disease should maybe be put on a maintenance strategy, which means continuous BTK inhibition. But fixed duration treatments in general can be a second choice here if there's a strong preference for a fixed duration treatment. They also have efficacy, but it's unknown how sustained this efficacy will be. So one trial in which we want to study the differential impact of different risk factors in the context of continuous versus fixed duration treatment is CLL17. In this trial, we randomized patients to continuous ibrutinib, fixed duration Ven-O, or fixed duration venetoclax ibrutinib. Over 900 patients have been enrolled in this European trial, and we will share results of this study also at ASH. One further point that is, of course, of high interest is which agent should we use when we try to target BTK or BCL2 and so on. And this is a new development, of course, of the last, let's say, 6 or 7 years, where next generation inhibitors have been introduced, and it's always difficult to develop a hierarchy of which BTK inhibitor should eventually be chosen. And the background of thinking about which BTK inhibitor to use or which generation of BTK inhibitors to employ is based on the toxicity profile, especially of ibrutinib, which has been studied a lot over the last 10 years and where thousands of patients have been treated worldwide, and where we know the toxicity profile nowadays quite well, especially the cardiovascular toxicity related to cardiac arrhythmia, but also things like bleeding and hypertension that are associated with ibrutinib. And so this is essentially the rationale for having next generation inhibitors that are more specific than ibrutinib and therefore have similar efficacy, as you can see here from the ELEVATE-RR study that demonstrated non-inferiority of A color to ibrutinib in terms of PFS, but significantly less side effects in terms of fewer atrial fibrillation, hypertension, and bleeding events compared to ibrutinib, even though, as you can see over time, there is a risk of developing these toxicities still, even on acalabrutinib. And we have a similar pattern for zanubrutinib, significantly fewer atrial fibrillation episodes, here demonstrated in the ALPINE study, comparing zanu to ibrutinib, and also suggesting higher efficacy to a certain extent. There are some limitations due to the study design, but generally you can see that the efficacy of zanubrutinib is quite high and potentially even higher than with ibrutinib, as I said, to a certain extent. The toxicity profile of fixed duration treatment needs a little bit a different angle when we try to interpret the toxicity profile. And the reason for this is that, of course, we are giving the combination treatment for just 1 year. And therefore, what we clearly see is that after therapy, there is no treatment-related toxicity anymore, which is, of course, extremely favorable and beneficial for patients, because this is in contrast to what you saw before, where you see over time accumulation of side effects because patients have to stay on continuous treatment when they are treated with BTKI monotherapy. What we do notice, however, is of course that because we are using multiple agents, we see more on-treatment toxicity when patients are on treatment. So the cytopenia rates, for instance, of 52% are much more than what you would see if you would use a single agent, which stands to reason, but I think is something that is clinically still meaningful and needs to be taken into account. For venetoclax ibrutinib, we see a similar pattern. You have more toxicity when you combine two agents than when you just use one of those. But you do also pick up some of the ibrutinib-related toxicities, even though the patients are exposed to them for just 1 year. So this is here from the GLOW study that's reported 14% atrial fibrillation rate for venetoclax ibrutinib compared to 2% for chemo monotherapy. This was an elderly unfit patient population, but you can see that there does seem to be a clear treatment association of the side effects, and naturally, therefore, this was a rationale to test next generation inhibitors also in combination treatments, and this is done, for instance, here with acalabrutinib and venetoclax from the AMPLIFY study, where you can see that the use of the next generation BTK inhibitor acalabrutinib is associated with a very limited cardiovascular toxicity. The major caveat here is that this is a young and fit patient population, almost 20 years younger than what you saw here from the GLOW study. And therefore, at this stage, in my view, it is almost impossible to say what's the contribution of the different demographics here, that we are looking at elderly and very unfit patients, and what's the contribution of the assumed lower toxicity of acalabrutinib compared to ibrutinib. And we, at this stage, have very little to no data on acalabrutinib venetoclax in elderly unfit patients. And so this is a huge data gap that, in my view, needs to be filled, because it's so essential that we understand how the toxicity profile of acala then is in the elderly and unfit patients. On that note, what's interesting is that we do have some complementary data from a different trial, the FLAIR study that tested ibrutinib and venetoclax as an MRD-guided treatment. So it's not really completely applicable to the setting that we have with fixed duration treatment, but the study is still interesting because it also generated interesting toxicity data, and you can see that the combination of ibrutinib and venetoclax in young and fit patients, so these patients are really much more comparable to the AMPLIFY population. You can see that the cardiovascular disorders or cardiac disorders are around about 14%. So it does suggest, when you compare this to AMPLIFY, that maybe the combination with acala is indeed associated with less toxicity in general. And speaking of first-line trials, we have one concept that is ongoing now in Europe, the CLL trial that tests MRD-guided treatments. In this case, it uses venetoclax or obinutuzumab and compares this to fixed-duration venetoclax pirtobrutinib and also MRD-guided venetoclax pirtobrutinib, allowing us to understand how MRD guidance compares to fixed-duration treatments. So this is, just to make justice to the title of the talk, Evolving Concepts, this is now the next step, given that we have robust evidence for the feasibility and efficacy of fixed duration treatments. The question is, can we move further by using MRD-guided treatment for first-line CLL? Now, just a few words at the end for relapse therapy. This is a little bit more complicated, and I've took this also from our recent update of the Oncopedia guideline, because the decision of what kind of follow-up therapy to use is really driven by the choice of prior therapy or the treatment background. And here it is essential to consider whether the patients were on continuous treatment or on fixed duration treatment. And the reason for this is that we know that with continuous treatments, the patients, when they progress, they become refractory to the prior therapy. So this is because they acquire resistance mutations that prevent the efficacy, in many cases, the binding of the specific agent to the target molecule. And this has been particularly studied with ibrutinib, but basically for all other continuous therapies, including venetoclax for that matter, we've seen resistance mutations described when patients were relapsing on continuous treatment. And this is different to fixed duration treatment, where no resistance mutations have been so far described when patients relapse. And this has been the case for VEN-O, but also for venetoclax ibrutinib, where these previously characterized alterations or mutations in BTK or BCL2 have not occurred when patients progressed. And so clinically, the consequence is that we should consider retreating the patients then, because biologically there is no indication of refractoriness, and therefore re-exposing the patients to the same agent seems something that is clinically sensible, and we have some data on this from some pooled analyses as well as from prospective subgroups from the Murano trial, showing that when you re-expose patients in the third and fourth line with venetoclax, that over 70% of those patients respond, and this has been also translated into progression-free survivals of approximately 2 years, again in very late lines of treatment, heavily pre-exposed and with a high-risk disease, where you gain at least 2 years of disease control by just re-exposing the patients to the same therapy again. And we are seeing more maturing data on this for venetoclax ibrutinib as well, where you see efficacy of re-exposure to BTK inhibition in particular, and therefore the retreatment concept, I think, is becoming more and more relevant and more attractive, I think, in the long run in managing CLL. In our treatment guideline, we therefore say that when you have a progression after a fixed duration treatment with Ven-O, you should particularly consider when the progression occurred. And we had long discussions, and the same applies to ESMO and most other guidelines, on what constitutes an early relapse that might indicate refractoriness, or a late relapse that might more suggest that the disease is still susceptible to the same therapy. And the guideline says something between 2 to 3 years of remission should be the threshold to distinguish a late from early relapse. And this is an interesting question because we don't have a good feeling or good database for saying what constitutes an early relapse in CLL. And as I said, in the ESMO guidelines, it says 36 months. In the Oncopedia guidelines, 24 to 36 months. And so for that reason, because this is quite an interesting question, we recently did a large analysis of almost 4,000 patients with previously untreated CLL who received a first-line treatment with chemotherapy or with targeted treatment. So roughly half of the patients had targeted therapy, and the other half chemomonotherapy. And we noticed that the progression within 12 months after treatment completion seems to have the strongest adverse impact on survival. So this means that it's similar to what you know from other lymphoma, like follicular lymphoma or mantle cell lymphoma with POD24. It seems that for CLL we have a POD12, because the relapses occurring later than 12 months did not have any impact on survival. And in fact, the patients had a similar survival when they had a late relapse as patients who did not experience a relapse at all. And so I think, therefore, we should move the definition of early versus late relapse more around 12 months rather than the 24 to 36 months. And naturally, when it comes to re-exposure to venetoclax, it naturally means at this stage re-exposure to venetoclax rituximab. So the Murano regimen that has previously demonstrated high efficacy post-chemotherapy with a median PFS of 54 months. The challenge is, of course, we have very little data on venetoclax rituximab post-BTK inhibitors. And this is here an interesting analysis from Australia, where they show that patients who are pre-exposed to BTK inhibitors and receive venetoclax rituximab, they might have actually a much more impaired progression-free survival than other patients who are only chemo exposed. And so there is still a clear need to improve the efficacy of fixed duration treatment in the relapsed space. And as you can see from the algorithm, at this stage we only have one fixed duration option in the relapsed setting, which is venetoclax rituximab, which of course is not effective enough, as you saw from the Kaplan-Meier plot. And so at the moment we have a couple of interesting studies exploring improved strategies for fixed duration treatment in the relapse space. There's, for instance, this trial, venetoclax rituximab versus pirtobrutinib, venetoclax rituximab, so triple treatment against double treatment in the relapse space, which is quite interesting. And then on the right here, our CLL-RR1 study, which has started recruitment a few months ago, not yet in Europe, but in South America and Australia, and recently also in the US, where we have where we are testing sonrotoclax, a next generation BCL2 inhibitor, and comparing this to venetoclax in the relapse space, and also exploring aspects like the combination with obinutuzumab instead of rituximab, and also the concept of MRD-guided treatment shortening for patients who achieved MRD negativity after a year. And then, as I mentioned, pirtobrutinib just before. Pirtobrutinib is another new option that we have in the relapse space, that in the guideline we have now moved up a bit based on the data on the BRUIN 3-1 study, because this trial showed that pirtobrutinib is more effective than idelalisib and bendamustine in patients who are pre-exposed to covalent BTK inhibitors. This is the only randomized study that has exclusively this group of patients. And the study showed longer progression-free survival with pirtobrutinib compared to idelalisib or bendamustine rituximab, and therefore showing that this should be the use of a non-covalent BTK inhibitor should certainly be preferred over the use of a PI3K inhibitor in CLL. And so to conclude maybe with this slide, I think what we have at the moment is these evolving treatment paradigms of continuous treatment and fixed duration treatment. And I think at the moment that we have the option to put patients on continuous therapies, and whenever a progression occurs, we have refractoriness and switch to a different kind of therapy. Let's say you use a covalent BTK inhibitor first, you have a progression, and you switch to a fixed duration treatment like venetoclax rituximab, and then the patient gets off therapy for the first time. But I think what's smarter, and where we are getting more and more data on the feasibility and long-term efficacy, is the concept of interval therapy. So we use a fixed duration approach for a fixed number of cycles. We get the patients off therapy. They have many years of therapy periods, or periods where they are in remission without requiring any medical interventions. And when they eventually have a symptomatic progression, we simply re-expose them again to the same combination, fixed duration treatment, and get them off therapy again. So over time, they will have much less therapy and much fewer medical interventions to control their cancer, compared to a continuous strategy that requires ongoing treatment and ongoing intervention and awareness on our side. And therefore, I think with the current developments, we are getting closer and closer to really implement interval therapy also in our clinical routine. So with that, I would conclude for now. Thank you very much for listening, and I look forward to the discussion. Thank you very much.
Thank you very much, Dr. Elzalva, for the excellent overview on the new sort of concept in the treatment of CLL, both in the frontline setting and also in relapse refractory setting. So maybe now I can also invite all the panel members to come on stage, and we can also start the Q&A session. So any questions for Dr. Elzalva at this point? Maybe I can start by asking the first question, Othman. Now, you mentioned that either for the fixed duration, you can use typically nowadays venetoclax together with obinutuzumab, or venetoclax together with another BTK inhibitor. Which option would you choose? I mean, for any patients, do you consider the comorbidities or the genomic profiles before you decide whether you combine venetoclax with an anti-CD20 antibody or a BTK inhibitor?
Yeah, that's a great question. And so far, only CLL17 has a randomized component. We will show some of these data at ASH, even though the follow-up is still short and the study was not primarily powered for the comparison of VEN-O versus VEN-I. But generally, I think you mentioned the main points. The comorbidity in my practice at the moment is probably one of the main decision drivers here. So we know that obinutuzumab has a certain degree of toxicity and side effects in terms of infusion-related reactions. Up to 40% of patients experience infusion-related reactions. And in fact, most of the tumor lysis syndromes that we observe with Ven-O occur post-obinutuzumab, before we even introduce venetoclax. And so therefore, maybe patients with very high disease burden and high risk of TLS, in addition to coexisting conditions, especially things like renal impairments, cardiovascular comorbidities. For these patients, maybe when they have high disease burden, the combination of Ven-O is too intensive. And the other component is infections. So when we have very vulnerable patients that already have a history of repetitive infections, it seems that the addition of a CD20 antibody increases the susceptibility. And this again refers to data that we'll show at ASH, where we see infections really being an issue with the CD20 antibody use. So for these patients, I would rather opt for the combination of venetoclax and a BTK inhibitor, generally assuming that the efficacy is more or less similar in the first few years. Personally, I believe that venetoclax obinutuzumab is probably the most effective therapy, simply because of the MRD data. So we always see across data sets the MRD responses are deeper. And also at the 10 to the minus 6 level, the fraction of patients achieving these very deep remissions are only possible when we use obinutuzumab. And with sufficiently long observation in CLL, MRD has always translated to PFS and survival. So it's a question of how long you observe the patients. You might not see a difference in the first 3 or 4 years, but I think if you have sufficient observation, naturally those who have still detectable disease will relapse earlier than those with less residual disease. But then the question is again, who needs this intensive therapy to benefit from this long survival, from this long PFS? And does an 80-year-old patient with comorbidities really need to clinically take the risk of side effects to gain these very deep remissions? Or do we have other more milder but equally effective alternatives? And so this is for me the main decision driver, so to speak, between Ven-I and Ven-O. In terms of the genetic profiles, I don't think at this stage we have sufficient data suggesting that Ven-I or Ven-A work better than Ven-O in higher risk disease. That we don't see at this stage yet.
Thank you very much. So any other questions? Perhaps also from the panel members, any questions for Othman? Stephen.
I'll ask one. Othman, Stephen Milligan here. First of all, thank you very much for a great talk at 3 a.m. in the morning for you. My question is, one of the reasons we held on to FCR for quite a while was because of the 50% cure fraction with the mutated patients. My question is, do you think there's going to be a cure fraction with VO? I mean, at 5 and 6 years, I think it's what, 74 and 72% are still in PFS. On a secondary note, we know there is one, and that's the data you've got from the CLL13 study. Unfortunately, it's just that 2% that have got the triple trisomy of trisomy 12, 18 and 19, which we knew had a 100% cure fraction with FCR, and looks like from your data, 100% cure fraction with venetoclax-based regimens as well. But with VO, what are your thoughts, and do you have any further updates on the mutated patients getting VO?
Yeah, thank you, Steve. I think that's exactly the point. Of course, we need to be careful with the word of cure in studies where we don't have the 15-year observations as we have with FCR. But generally, as you pointed out rightly, the 6-year PFS rates and the 5-year PFS rates that have been seen with VO suggest even they are almost 20% higher than what we saw with FCR at a similar stage when at 5 years. So this does suggest the potential that we could also see even a higher plateau, so not 50%, but maybe 60% of patients achieving these long-term remissions. So I'm quite confident and quite optimistic that this will be the case. And I think that for mutated IGHV, again, alluding to some of the data that we show at ASH, the CD20 antibody seems to be the key for these. So if we want to achieve a sort of cure, then CD20 antibodies for mutated IGHV at least are essential, because there we do see these extremely good disease control rates also with Veno. So I'm quite optimistic that we will see similar, if not better, long-term outcomes for mutated IGHV. For unmutated IGHV, very surely not.
Any other questions from the floor or from the panel members? Yes, Harris?
Hi, Professor Osman. Haris Rahman from Kuala Lumpur. A very interesting talk, but again, it opens up the idea of all these options that we have. So with so many regimens that we have, the BTK, the BCL2 inhibitors, the combination sequential and all that, it feels like speed dating all this. And how do you pick your first date and to avoid long-term toxicity divorce? It's up to you.
Thank you for this nice comparison. Yeah, so I think especially for the first line setting, the key question is the consideration of what will be my next step for this patient. So regardless of what kind of first-line treatment I choose, I think nowadays it's more important than ever to also consider what will be my second and third-line consideration for this patient. And this includes, of course, again, to use the example of the 80-year-old patient, where the considerations around the second-line therapy might not be that relevant if they have like a mutated IGHV CLL, because they will probably be more impacted in their life expectancy by other comorbidities than their CLL. And so the treatment sequencing consideration might not be that relevant. For a 50-year-old patient with, let's say, TP53 altered CLL or even just unmutated IGHV, I think, again, the choice of the first-line treatment should also take into account what would be my second and third-line step. And this is because if I say for a patient, let's say with unmutated IGHV, who is 50 years old and fit, if I say I want to put them on a continuous BTK inhibitor with a covalent inhibitor, let's say Acala or Zanu, then this means that first of all, the patient has to stay on the treatment for multiple years, typically 6 or 7 years at least. And also that once the patient progresses on that, that's it for the covalent BTK inhibitor, at least as far as we know. So once the patient has become refractory, these clones have such a selective advantage over others that the other covalent inhibitors will not work anymore for this patient. And therefore, we've exhausted this option for these patients. So when they relapse again, and they are 57 or 58 years old, we only have the BCL2 inhibitors and the non-covalent BTK inhibitors left, so to speak, and the CD20 antibody. And so this, I think, for these patients, I think it's extremely important to therefore also consider the treatment sequencing consequences of my treatment choice in the first line space. So I think this makes the decision making a little bit more complex nowadays, that we, when it comes to choosing a first date or the first option for the patient, that we really need to think far ahead to consider the implications of our treatment decision, especially because we can have with our treatment choice a really profound impact on the biological and composition of the disease. And yeah, so I think therefore the age and the general life expectancy of the patient informs the relevance of treatment sequencing, and this consequently informs what kind of strategy, especially continuous versus fixed duration, then is more suitable for the patient.
Yeah, just to follow up to your point, which is once you pick a BTK and if the patient progress on it, you basically have to exhaust it. So on a practical point of view, do you think that switching BTK is not going to actually make much difference? And along the same line, between the three that we have available, which one do you prefer, or you remain neutral politically? You want to say which one or which? Which one do you prefer?
Thank you. Politically, there's or we don't do medicine based on politics, or we shouldn't. I think the challenge is when it comes to we basically have 4 BTK inhibitors at this stage, with 3 covalent, as you said, and the 1 non-covalent that we have now, the pirtobrutinib. Generally, when I put patients on continuous BTK inhibitors in the first-line space in particular, where I only use covalent inhibitors, even though we will see encouraging data at ASH on pirtobrutinib also in the first-line space. But even with those data, I don't think there's a clear rationale for using non-covalent inhibitors at this point in the first-line setting. But when it comes then to the 3 covalent inhibitors, I don't use continuous ibrutinib anymore, even though the efficacy is quite evident and it's a highly effective agent, but it does have substantially more toxicity, especially in elderly patients above 65 years, compared to the next generation inhibitors. And between acalabrutinib and zanubrutinib, it really depends a little bit on the risk and the profile of the patients. This is more not really evidence-based because we don't have prospective data comparing acala to zanu. And my personal clinical impression is, from having used both of these agents, I haven't seen like a particular pattern or enrichment of side effects with one or the other agent. So for me, I personally believe they are equally effective and equally tolerable or non-tolerable, without any robust difference in their profile clinically, at least. But still, based on the data that are out there from ELEVATE-R and the Alpine study, I tend to use zanubrutinib more in the higher risk disease, simply because there's a slight trend of superiority, especially in the TP3 alpha setting for zanu compared to ibrutinib. Whereas for patients with very high cardiovascular risks, where I don't use a BCL2 inhibitor, I prefer acalabrutinib because acala had more advantages over ibrutinib in terms of atrial fibrillation, similar to zanubrutinib, but also in things like hypertension and bleeding, which were equally common with zanu compared to ibrutinib. So zanu, in terms of toxicity profile, really only had an advantage in the atrial fibrillation rate. All other side effects, like bleeding, like hypertension, and other cardiac toxicities, were equally common between both, which is different to acalabrutinib. So therefore, for these patients, I'd rather use acalabrutinib when it's more focused on efficacy and higher risk disease. I tend to use more zanubrutinib, but again, this is really just based anecdotal, and my personal expectation is that those agents are equally effective and equally tolerated in that class. And as I said, the pirtobrutinib might be the best tolerated BTK inhibitor, looking at the toxicity data that we've seen so far from the different pirtobrutinib trials. But because the resistance profile, and this again really highlights how necessary it is to think about the long-term consequences of treatment sequencing on the treatment sequencing in CLL, it's becoming more and more relevant. And with pirtobrutinib in particular, and the non-covalent inhibitors in particular, this is particularly relevant because we know that the resistance mechanisms that lead to pirtobrutinib refractoriness most likely will lead to refractoriness also to covalent inhibitors. In other words, the sequence acala or zanu.
I think we probably have lost the connection here. So in any case, we can start off with the panel discussion now. And anything to say?
No. So Eric and Li Jianyong, you all take over.
Yes, okay. Yeah, well, now we can kick off with the panel discussion.
And also Steve can also chime in. All of you can discuss among yourselves.
Right, okay,
Let me ask you all the questions, or maybe your kid has a question. You know, is it specific for Osman or for anybody? Okay, so let your kid.
I'm Dan from Penang. Can I just ask, how do you approach a patient who has early relapse after covalent BTKI? And is there a way to check for BTK mutations, or you will just switch to a non-covalent BTK inhibitor, because non-covalent BTKI is still not available in Malaysia yet? Early relapse means not progression, it's early relapse like 36 months before the cessation.
We face the same situations in Thailand, so I think I would pass on for your opinion.
So if someone develops BTK resistance, first of all, we can actually now measure it as of about 18 months ago because we can do routine gene panels that are funded. And so you'll most frequently see cysteine 481. I think what Othman was getting onto just before the line dropped out was the risk of getting another mutation that blocks both, namely the L528, and that can occur with both XANU and also PERTO, and there's the risk of cross-resistance. But briefly, if someone becomes BTK resistant, I change them over to BCL2.
We don't have tests for mutation in our hospital.
Oh, we don't have that test routinely in Taiwan. So, and also currently we don't have the second line treatment options in reimbursement. So it is mainly the second line treatment choice actually mainly depend on the discussion between patient and the doctor.
Right. Also in Hong Kong, we don't actually routinely test for BTK mutation after a patient who relapse after long-term BTK covalent BTK inhibitor. But I think, and also pirtobrutinib is not available in Hong Kong. So what happens is if patient relapse on continuous BTK inhibitor, we'll put the patients on venetoclax together with an anti-CD20 antibodies. And the choice of anti-CD20 antibodies will be sort of debatable, although, I mean, only rituximab combined with venetoclax is kind of licensed indications, but very often people these days will use obinutuzumab combining with venetoclax as the second line.
Because pirtobrutinib is not approved for sale in China, but in practice, if we use pirtobrutinib for patients failing covalent BTK inhibitor, our patients will use next generation sequencing for BTK mutation.
So
I might just make one other comment, and that is that at the end of the day, it's a clinical decision. Because even if you've got BTK mutational status available for either BTK or PLC gamma 2, they're only present in a bit over 50% of patients that get clinical resistance. And in fact, if you see a BTK mutation and the climbing VAF, at the early stages, they're not actually clinically resistant anyway. They've got to have a VAF way over 50% before they start getting a lymphocytosis. So it's a clinical decision at the end of the day.
So PERTO is actually available in Singapore, and I'm talking to Eli Lilly and DKSH. I think they have plans to roll out and to the region, so it will eventually come to everybody. Actually, my question was for Othman. I see that allo transplant is inside there, and I guess I want to ask the panel, where do allo fit in? And in the setting of T-cell engagers coming on board, bispecific CAR T in China, I'm quite sure you have a lot of CAR Ts. Where do you see that changing your role for allo transplant, and in which category of its oncopedia? A little bit complicated, but I guess, yeah.
For us, normally, we normally don't do allo transplant for CLL normally, but only would select it for patients with Richter transformations. And currently, we don't have CAR T cell for CLL in Thailand. Yeah, but mainly allo would be offered for maybe Richter.
Assuming eventually it will come to everybody, and where do you see that fitting in the landscape? Steve? Anybody?
So look, I think progressively CLL is falling off the bone marrow transplant list of indications. First of all, we've got vastly better. I mean, one of the comments that I see, we've got Othman back again. Hi, Othman. But I mean, one of the issues we've got at the moment with CLL, they're all great therapies. And really, whether you use BTK monotherapy, VO, or a triplet, or if you've got them, or a BTK plus BCL2, they all result in fantastic outcomes, that many of which are durable for a long time. And then, of course, you can swap agents. As you just pointed out, we've got both bispecifics that we don't have all that much data on, non-covalents, which are basically acting like a new class of drugs, BTK degraders, which are also acting like a new class of drugs. So the huge proportion of patients with CLL are going to transit through their course of their disease before and by the time of which they'll then be too old to be transplanted anyway.
Can I ask a question? Yes. I'm glad you are back, Osman. Thanks for the talk. Actually, for treatments of CLL, I think cost is an issue, and now we are knowing that mutation will be an issue also for those who are continuing on treatments. I wonder, is there any data for those patients stop the drug because of side effects, the outcome of those patients compared to those who continue with the treatments? And my second question is, can we use best response to decide when to stop the treatments? If you are talking about fixed duration, just like myeloma, when they are not responding, whether that's the time we stop the treatment and wait for the next treatment. Thanks.
Yeah, thank you. These are excellent points. For the stopping in the context of continuous BTK inhibitors, we see that when you stop for side effects in the first-line setting, there are some data from the ECOG 1912 study that showed this nicely, that the time to symptomatic progression after discontinuing ibrutinib due to toxicity was over 2 years. And most of these patients had stopped therapy after exposure, I think, of 18 months or something. So it does suggest that even stopping the BTK inhibitor when you are not in a complete remission, which the majority of patients on BTK inhibitors don't get to, that you do not immediately get relapse or require an next-line therapy. Now, the caveat here is that we don't have any good objective measures to decide when patients on a continuous BTK inhibitor have enough therapy. So we can't use MRD to quantify this, because most patients with BTK inhibitors stay MRD positive forever. So we can't use that. And the only way would be to use some crude clinical measures to, as you mentioned, from like the myeloma space also, where maybe you could say, if you feel that the patient is in a stable remission, that at some point you decide to at least pause the treatment. There's one interesting study from the UK, the STATIC trial, that tries to test this prospectively, looking into patients who are already on a covalent BTK inhibitor and who, when they have at least a somewhat normalized peripheral blood count, that they can get off therapy and then are put again on treatment when they require therapy. So these are possible concepts. Not sure this will be, whether this is, it might be beneficial from a cost perspective, because every year that you don't use the BTK inhibitor can mean, in Germany, ibrutinib monthly costs almost like 4,200 euros approximately. So yeah, within 1 year you do, if you stop ibrutinib for 1 year, you do have a lot of cost savings for sure. But in the long run, it's questionable whether, I think, 1 or 2 years of treatment-free periods are that sufficient to say that this is like an incremental advantage. So yeah, so that's a little bit the challenge. For when it comes to fixed duration treatment and earlier discontinuation, it's quite interesting. We recently published a paper on this for VNO, where we see that when you get to a reduced dose intensity below 70% of venetoclax, then you start seeing significantly shorter PFS and shorter and lower MRD responses. beyond that, if you have dose reductions of the cumulative dose to 80%, for instance, or so, due to dose reduction because of toxicity and so on, then you don't see any difference in MRD or PFS at all. And I think this motivates us to say that when you have treatment intolerance, and especially when patients don't seem to tolerate 400 milligrams of venetoclax due to repetitive cytopenia and so on, and where you then decide to stay on 200 or 300 milligrams for a while, that these patients can still gain extremely good outcomes. So therefore, rather than discontinuing the treatment for these patients, I think there's a good rationale to say continue with dose-reduced venetoclax and in order to at least have a certain degree of efficacy.
Yes, perhaps last question.
Okay, it's potentially a big one. Othman, look, can I ask you about one of, for want of a better word, orphans of CLL therapy, namely the patients with autoimmune complications? As we were touching on, we are now very good at treating CLL per se, but the patients with autoimmune complications, some 20% of the entire population, have often been routinely excluded from clinical trials. So if they fail steroids and perhaps rituximab, when and where do you go then? And when and with what do you start treatment for the CLL?
No, thank you, Steve. Yeah, that's a great point. As you say, in most clinical trials, including in ours, like an uncontrolled autoimmune hemolytic anemia would be an exclusion criterion. And therefore the evidence, especially for specific targeted therapies being better or worse than others for controlling autoimmune hemolytic anemia or steroid refractory autoimmune cytopenia is a little bit challenging to say. My go-to typically is if I have a steroid refractory cytopenia, rather than mingle around with CD20 antibody monotherapy, I typically see this as an indication for CLL specific therapy and then doing it properly. So meaning either say I want to stick with a BTK inhibitor or a combination treatment. What I always try to do is use BCL2 inhibitor in combination with a CD20 antibody. I think because I want to use the CD20 antibody component, and rather than just using it as a single agent, and therefore maybe if indeed the CLL is the main factor fueling the autoimmune condition, then I want to have a deep response or MRD eradication as much as possible in order to remove this trigger, so to speak, just in theory at least. And so this is typically my go-to strategy for steroid refractory cytopenias, that I put them on obinutuzumab and venetoclax, or in the relapse space on venetoclax and rituximab. Generally, though, there are reports out there showing that single-agent BTK inhibitors can be also extremely effective in that setting, especially in those who have been exposed to rituximab monotherapy and have not shown enough control.
So thank you. So in the interest of time, I think we have to close this session and move on. So with that, thank you very much, Dr. Alsalva. So I hope you can go back to bed and have some rest before the next, for the weekend. And also I would like to thank all the panel members and thank you very much.
Thank you.
Thank you.